we'll do extension. So I'll have him, I'm gonna stabilize opposite side, or both sides actually, here, and keep hands on the ASIS to make sure there's not pelvic movement. So I'll have the patient bend their knee to 90 degrees, and then just push your foot straight up towards the ceiling. Great, so we're looking for 10 to 15 degrees of hip extension here. In a perfect world, I would have a tech or another PT help me measuring while I can keep range. Sometimes that's not possible, so you may not be able to keep both hands on the pelvis while we do all of those things at once, but perfect world. Okay, and then similarly, of course, if that's tight, we're looking at rec fem, we're looking at TFO, we're looking at hip flexors, anterior capsule tightness. Okay, so now going into internal and external rotation, this is very similar to the Craig's test, which according to our books is not super reliable just because of patient BMI differences across the board, but is more reliable as the patient has basically less body fat. You can rely on that test a little bit more, but here, again, stabilizing, we're doing internal and external rotation. Internal is 20 to 45, external is 30 to 45. So we'll have the patient hold that there, do that on their own. Internal rotation, measure external rotation, of course. We'll take a measurement, look for concordant pain. Again, looking at the piriformis, since we are in now a hip extended position. So it is now fully a rotator or an external rotator in this position. So any internal rotation tightness might implicate some piriformis dysfunction there. And then while we're here in this position, we can, if none of those are reproducing concordant pain, we can do combined motions. So similar to the position we were just in, we can do extension, abduction, and external rotation, which brings us into the military crawl or frog position, depending on where you went to school, which is one of our combined motions here. Obviously looking at capsular tightness, anterior capsule tightness. You can use this as a joint mob as well, and actually tuck this leg underneath. You can tuck that leg. Stabilize and provide, come on this greater trochanter and provide a PA force there, and get a really good anterior capsule mobilization. If they can tolerate it, same rules apply. We'd be looking for, can I reproduce symptoms, can I not? Okay, I might look at combined motions. Also can do external rotation, a deduction, internal rotation, as well as a combined motion, looking at anterior capsule on the other side. Yeah, and of course then we can do standing, looking at squat, looking at lunge, forward lunge, lateral lunge, deadlift, step up, step down, which is great test, treat, retest around some of the techniques that we do to measure hip flexion, where they get their P1, do our treatment, come back and retest the functional standing hip flexion. Okay, so finally, looking at passive accessory motion. I'm sorry I'm going long. So we just did the frog position and prone. We can also do just a prone PA. For the sake of this video, I will stand over here. Normally I would stand on the other side and reach across to stabilize, which I guess I could do that. I can reach across and stabilize, you just can't really see. I will use internal and external rotation, of course, to find the greater trochanter so that I know where I'm at. I'm on the femur and not just pressing down on the pelvis and not getting actually into motion. Stabilize at the opposite pelvis. Not the best table height here, but then pressing straight down, getting a PA force for the anterior capsule. Anything else in prone? Go ahead and turn on your side facing me. The way that Chad Cook does most of his mobilizations was sidelined, which I actually haven't seen, so scoot down a little bit. So he actually has both of his hands. He comes onto the greater trochanter here, okay, and he'll actually get both thumbs, and like for this instance, we'll be on the anterior side of the greater trochanter, and he'll fulcrum almost like this, his hands to provide a P force here. And then I can stand on the opposite side and do the exact same thing for a PA. Force there, and then he also he'll have the front leg for a little bit more intensity. Be here, the top leg be in front of the bottom leg a little bit, and he will again get on that greater trochanter and do a distraction force and sideline and press straight down in line with the femur, straight down, and get a very true and direct hip distraction move there, okay? Make sure I'm not missing anything, okay? And now lay on your back. So just kind of quickly going through these. Now in supine, of course, we can do the AP, and I'll reach across here. So finding our greater trochanter, making sure we come here next to it, stabilizing and pressing. And we like to be in line with that hip joint as well, to get the best kind of move for posterior capsule there. And you can change, I've seen people change the way the hip is positioned for this one to stress different areas of the joint as well. So supine, okay. And then of course we can do our supine distraction. Now this is the indirect distraction technique because you'll also get distraction at the ankle and the knee as we literally just come into a little bit of flexion, abduction, and a little bit of external rotation. I'm gonna hold my table and give it a backwards pull here, a long axis pull. That's not as direct. You can then turn that into a thrust. But to be, I'll come to the other side again, a little bit more direct, we can actually have the leg over the shoulder. We like to use a towel here or a belt, but pull straight down into a more direct hip distraction. And again, you can change your angle to make it a little bit more in line with the actual hip joint rather than just more of an inferior glide, which is what the first one I did. And again, I like to use a belt and a towel to then come to a lateral distraction, straight out to the side, but usually using a belt and a towel. But this is my husband. So in the actual clinic, we'll use that or a pillow. Okay, and that's a little bit more directed straight at the femoral acetabular joint. So patients with OA get a lot of relief from that. Again, I'll list my citations in the text box at the bottom, and please let me know if I missed anything.